Sorry for the delays. So we are back. So we are on heart attack. Firstly, heart attack comprises of unstable angina and myocardial infarction. Generally, it's caused by...
Please, can we pay attention, please? Can we just keep quiet? Thank you very much. Break time is over. There's so much chattering. If you are eating, eat quietly, but your ears open and your hand on your biro. Eat with your left hand, your right hand on your biro. This is war. Thank you very much. Let's pay full attention, please. This is a very critical topic. And then after this, we're going to ACLS.
Heart attacks comprise of unstable angina and myocardial infarction. It's usually caused by fissuring or rupture of a plaque, atheromatous plaque, on the coronary vessel wall. It can come as chest pain, but sometimes as what we term as ulcer pain, and sometimes can come non-specific. There are instances where people present with just difficulty breathing, or sometimes they just feel fatigue. And this kind of so-called silent acute coronary syndrome are common in elderly patients, people with diabetes, female folks, and the like. So we should know the varying way it can present. So it's not all epigastric pain or upper abdominal pain that is ulcer, as was highlighted earlier. So this is the vessel wall. The primary cause of acute coronary syndrome is atherosclerosis. So it starts with damage to the vessel wall. So assuming this is the vessel wall here, you can see this yellowish thing. These are plaques. Before this fat becomes deposited on the vessel wall, there is the initial damage to the vessel wall. It's precipitated by things like hypertension, diabetes, hyperlipidemia, smoking. Now, you can have a narrowing of the vessel wall that is stable. It did not rupture. That can give you chest pain, like angina pain. Chronic pain is only when you exert yourself, you feel the pain. But in terms of acute coronary syndrome, we are talking of a rupture of this plaque that causes a total or near total occlusion of this vessel and impairment of blood supply to the coronary arteries, by extension to the heart muscle. Is that clear? Did that make sense? Thank you. So that's atherosclerosis. So heart attack is caused by a rupture or fissuring of this plaque that eventually leads to total or near total occlusion of the blood vessel. Then patient presents with what? Acute coronary syndrome. So this presentation is to be simplified. If we are to talk of ischemic heart disease and acute coronary syndrome, we're going to take more than a day. But we want you in the audience to be able to make a diagnosis, to be able to do the initial thing for the patient, to be able to refer for appropriate therapy. So we have simplified it into these 5 steps, the diagnostic framework. What's the first step? Chest pain. Patients with heart attacks present with chest pain, sometimes with upper abdominal or epigastric pain. The second thing is, I hope you are writing, please. The second thing is they have a positive ECG. What are we concerned about here in the ECG? Earlier we had ECG presentation where we are talking of the ST segment. We said the ST segment can go up, ST elevation, or what? Down. We also talked about the T wave, that the T wave is usually upright except in what? AVR. And we said once it's down, it is what? Not good. So positive ECG in this instance, we are talking of what? ST elevation going up or down, and a T wave going what? Down. The third aspect is a positive enzyme. By enzyme here, we are specific, troponin I or troponin T. Then the fourth aspect of your initial review and evaluation of a patient coming with heart attacks is what? Assessing their cardiovascular risk. So it's just to know if they are diabetic or hypertensive, if they have a family history of premature death that is likely from acute coronary syndrome, if they have elevated lipids and the like. After that, number 5, we have urgent medical treatment, which we are going to expatiate on. Then reperfusion, if they are candidates for reperfusion. So these are the 5 basic things we'll be talking about. So this is our approach. When somebody comes to you, severe chest pain, sweaty, vomiting, it could also be epigastric pain, as we've been reiterating since. You do a quick check, quick history, physical exams. The history should tell you if it is really typical for acute coronary syndrome. You want to check their blood pressure, be sure they don't have excess fluid, they are not in heart failure and the likes. That's what we mean by hemodynamic status. Then you do the ECG. And that ECG must be done 5 to 10 minutes of first clinical contact. Anybody with chest pain at all, anybody comes to you, chest or epigastric pain, for the first time, severe enough for them to present to you, you should do an ECG within 5 to 10 minutes. Then the third aspect is what? An initial troponin that should be done. And sometimes the initial troponin can be negative. We want it repeated within 3 to 6 hours. Because sometimes you are picking the chest pain early, and the effect on the troponin is not shown yet. In the next 6 to 12 hours, it starts rising. That rise or even fall of troponin is also pointing to a heart attack. So we said earlier that heart attacks or acute coronary syndrome comprise of what? Unstable angina and what? Myocardial infarction. Now, we have this simple table to help us classify it. If someone comes, let's look at the table. If someone comes to us, they have chest pain, typical as we have described. But you did their ECG. The ECG is not showing significant ST elevation now, or Q waves, particularly ST elevation. So that means the ECG is what? Positive, right? Then their enzyme, you did their cardiac troponin. Their cardiac troponin is also what? Elevated. They are going to be what? Diagnosed at what? STEMI, ST elevation myocardial infarction. On the other hand, patients can come with the chest pain we described. The ECG is not showing ST elevation now. You can show other things, ST depression, T-wave inversion, but their enzymes are also what? High. The troponin high or T is elevated. We say is what? Non-ST elevation, myocardial infarction. So what defines MI now? The positive enzyme. Because when somebody has an MI, it's a what? It's a significant occlusion that is causing cell death. The muscles are dying. And the troponins are secreted from the what? From the dying muscles. So myocardial infarction just means that the cardiac muscles are what? Dying. So when you see an elevated troponin in this context, we say the what? It's MI. The only thing that will tell us if it's STEMI or STEMI is what? ST elevation. Is that clear? Are we listening? That's clear. Good. But sometimes patients can come acutely. All the type of chest pain we've talked about, they don't have ST elevation on ECG, and their enzymes are normal. We say they have what? Unstable angina. So somebody comes to you, severe chest pain, or they had a previous angina that is getting worse, or an angina that used to last 10 minutes before, and now it's 30 minutes and they're not getting relief. Or this is the worst pain they can describe, and they're just presenting for the first time. You think acute coronary syndrome, but the enzymes are what? Normal. We start calling that what? Unstable angina. Yes, the last box here is here. In that sometimes you will see someone with ST elevation on ECG, but the initial enzyme is what? Negative. We say from our initial presentation, you have to do a recheck in what? 3 to 6 hours. if you do repeated troponins and it's now high, that's likely ST elevation still. But sometimes there can be other differentials, other causes of what? ST elevation with what? A negative troponin. And some of them are like things like pericarditis, myocarditis, and the like, which we are going to talk about. Are you with me up to this point? Any question at this point? No, yes. Okay. So this is just reiterating what I've said earlier. So unstable angina, no ST elevation, enzymes are fine. We say it's unstable angina. Non-ST elevation myocardial infarction, we don't have ST elevation, though we can have what? ST depression, T-wave inversion, or the ECG can look seemingly normal, but the troponins are high. We say is what? Non-ST elevation myocardial infarction. But if we have typical ST elevation, new left bundle branch block, we were trying to explain what left bundle branch block means earlier. We said bundle branch block is usually wide complex, wide QRS complex. We're going to show an example later, but wide QRS complex usually signify bundle branch block. So if you are seeing a left bundle branch block for the first time in a patient with typical chest pain, together with positive troponin, that is, the troponins are elevated, that's what? ST elevation myocardial infarction. So this is what I was saying earlier about partial occlusion versus total occlusion. Generally, complete occlusion of the thrombus from that ruptured plaque will give you STEMI. And that's what gives ST elevation. But sometimes it's partial, so it can give either NSTEMI or unstable angina, depending on if the troponin is positive or not. So we are going to take a case. We are going to use this case throughout this lecture. I want us to pay close attention to it. It's just to highlight the salient points we've started with. Our patient is a 52-year-old male presenting with severe retrosternal chest discomfort. Now you can say, I say chest discomfort, not chest pain. Because for some people it's not pain, it's more of heaviness. Some will even say it's like an elephant sitting on their chest. Some will say it's just like something is squeezing their chest. That's why I use discomfort. Or 5 hours duration. Chest was sweaty. He had an episode of vomiting. The relatives reported that he fainted once. The pain was radiating to the left arm and the neck. He was recently diagnosed hypertensive, but not yet on medication. He's not a known diabetic. I've never checked his lipid profile before. Does not smoke or take alcohol. He was referred from another facility. There, they already taken Acute Coronary syndrome. So they gave him aspirin, 300 milligram start. Clopidogrel, 300 milligram start. When he was rushed to Cardiocare via ambulance, presenting pulse rate was 102 per minute, blood pressure 140/70. The jugular venous pressure was raised, heart sounds were 1 and 2. He was tachypneic, respiratory rate of 30. His oxygen saturation was low at 89% in room air, and he has fine crepitations in the lungs. However, the initial troponin at the referring hospital was 0.16 nanogram per mil, and the normal is 0 to 0.3, so it was normal. So back to the next, this is the question. What is the first step in the management of this patient? From what we've highlighted, we listed 5 steps earlier. I hope you took note. So what's the first step? 1, if you choose any, just say yes or no. 1, take sample for a serum troponin level. Yes or no? If you say yes, anybody saying yes, can I see the hands? I should go back. The steps? No, we are coming to that, sir. So, yes or no? Take sample for a serum troponin level? No. Send for emergency echocardiogram? No. Do a 12-lead ECG? Do an urgent chest X-ray? So the first step is what? You start with an ECG. So we go back to our steps. We said the person has presented. You've already defined the chest pain. You think you are thinking acute coronary syndrome. The next step is number 2. ECG. You are looking out for the positive findings. I hope that's clear. Thank you. So that's the answer, a 12-lead ECG. So there are some points. We will keep repeating them because we don't want people to miss them. If we say heart attacks are the most common cause of cardiovascular death worldwide, but we are not seeing much. That means people just die. You just hear somebody has finished his building, then collapsed and died. Somebody was praying and died. Somebody was in the prayer house and died, all sorts. That means we are missing them, so we don't want that. That's why we will be specifically pointing out these things and repeating them. Everyone with ongoing acute chest pain or quote-unquote ulcer must have an ECG within 5 to 10 minutes. It's 5 to 10 minutes. So it's not that time you will now start clacking for 1 hour. Not every abdominal pain is ulcer. In Nigeria, there are certain diseases that are common. Malaria, typhoid, and ulcer. Some will tell you every 3 months, they treat them. So, and we don't want to forget that it's not all the time that patient will present with classical chest pain. So I said earlier, some people can present with just tiredness. Doctor, I used to take 5-kilometer walk every morning. Yesterday, just on 1 kilometer, I was already panting. And it came to you that same day. You should think, especially if the person is hypertensive, diabetic, elderly, or middle age, start thinking what? Acute coronary syndrome too. So we call those ones angina equivalent. Epigastric pain, difficulty breathing, exercise intolerance. So we don't want you to just think of ulcers alone. So this is how to know ST elevation or ST depression. You were taught this earlier. This is the P wave, the Q wave, the R wave. This is the normal. P, Q, R, S, T. Sorry, the R is not prominent there. But when we say ST elevation, we mean that this segment that is in line with this is what? Pushed up. So when ST goes up is what? ST elevation. And when it goes the other way is what? ST. Excellent. Thank you. Then sometimes the T wave itself, we said T waves are always positive, except in what? AVR. So once you see a downward T wave, is what? T wave inversion. Good. So ST elevation, ST depression, T wave inversions, they are the positive ECG changes we are talking about. Is that clear? And we said they are usually grouped. Once you see one in the lateral, any of the lateral leads, you must look for other lateral leads. Good. So we have 2, 3 AVF for the inferior lead. Lateral leads are as listed and all that. So we'll be fast. So this is just pointing to what we said. 2, 3 AVF inferior lead. Anteroseptal is V1 to V4. Lateral is what? 1 AVL, V5, V6. So this is the patient's ECG. Let's look at this quickly. The patient's ECG. Can we all see this? Good. This is the patient's ECG. So the question will now be, the next question is, what is the cause of this chest pain based on his ECG? Inferior non-ST elevation myocardial infarction. Number 2, anteroseptal non-ST elevation. 3, inferior STEMI. 4, acute pericarditis. So if you go for inferior end STEMI, anyone? Only one person. Anteroseptal end STEMI. So we should go back. I'm giving you answer. But it's fine, don't worry. So we can see the inferior leads. We can see the ST segment is going up here, right? Also here and here. We also have ST depression in other leads. But when you see ST elevation together with ST depression. The primary problem is the ST elevation. The ST depressions are reactive. They are just like a response to it. So this patient, from this lead, 2, 3, and AVF has what? Inferior ST elevation myocardial infarction. So the first step is always an ECG. Is that clear? Thank you. So it's inferior STEMI. So what's the most important blood test you want to send to the lab immediately? Troponin high. Yes. Thank you. So again, the steps: chest pain, positive ECG, positive enzyme, cardiovascular risk factor, then urgent medical treatment and reperfusion. So troponins are invaluable. You can't do without them in diagnosing this patient. And we said earlier, a negative troponin, especially patient presenting with suspicion of acute coronary syndrome, you should repeat again, Abi, in 3 to 6 hours. Thank you. Now, sometimes there are other causes of elevated troponin. So sometimes patients come with chest pain, troponin is elevated. We eventually diagnose other causes. But we won't focus on all these other causes. We would rather focus on what is most life-threatening and can kill the patient. It's better we are safe than what? Sorry. So it's just that generally sometimes for the expert or the specialist, the way they present, we can see which type of pain it is and all these other causes. So these are some of the other causes of elevated troponin. Remember, somebody was talking about elevated troponin in pulmonary embolism earlier, right? So pulmonary embolism is a cause. Stroke is a cause of elevated troponin. It's not too far-fetched. All of them are involved in certain form of thrombosis or the other. So now, I've defined all these earlier, so I will skip them. These are some of the, I've shown you this, inferior STEMI. Now, look at this ECG. Where is the ST elevation? Anyone? Anyone? So we have ST elevation in V1, V2, V3, V4, and V5. Excellent. So this is what? Anteroseptal STEMI, Abi? STEMI or STEMI? STEMI. Thank you. So this is a bundle branch block. We're going to talk about, or maybe when we do our practical session. So I will not disturb you about that. We have also defined STEMI earlier. We said in this case, patients come with consistent symptoms with acute coronary syndrome. They have ST depression and or T-wave inversion, but no ST elevation. And their troponins are what? Elevated. Is that clear? So this is ST depression. Can anybody show me where the ST depressions are? Anyone? So we have ST depression here. Lead 2, lead 3, AVF, right? We also have some in V4 and V5. So this is what? N-STEMI. So this patient coming with typical chest pain, elevated troponin, and this ECG has what? N-STEMI. Good. An unstable angina can come in various forms. The most important thing is there's no ST elevation and the troponins are fine. But we said it can either come as somebody that is coming with a prolonged angina lasting more than 20 minutes, or they just come with a new angina that is very bad. They are sweaty, panting, they are in severe pain. Or they already had an old angina, but this time around, instead of having it maybe once a week, twice a week, you have increasing frequency, or it's becoming longer, or the amount of effort they must go through to develop angina is lower. Maybe before, they used to have chest pain when they walk 5 kilometers. Now it's every 1 kilometer. That's also worrisome. Then, of course, sometimes angina can occur after they've had a previous myocardial infarction. You start thinking of a stable angina. These are technical terms, but it's worthy of note. So back to our case. Our patient did, we said the initial troponin was 0.16, average of 0.2. So on presentation, we repeated it. It was 2.3 nanogram per ml. So it's now elevated. Is that clear? The cholesterol was high. LDL cholesterol was 160 milligram per DL. Normal should be less than 100. N-terminal pro-BNP was high. Creatinine was normal. So this is what we did for him. We nursed him in cardiac position. He was placed on oxygen. Because of his severe pain, he had morphine, 10 milligram start. We don't want him vomiting, so we gave an episode of a shot of metoclopramide. Then we continued the aspirin at 75 milligram, clopidogrel at 75 milligram. So this is going to be a bit hardness. So this is our diagnostic framework. So we have talked about, we've discussed all this. We've discussed the chest pain, ECG, enzyme. We said is a recently diagnosed hypertensive, Abi. So we have also picked another risk factor now, which is what? The lipid. He was not diagnosed with hyperlipidemia before, but on presentation it was high. So he's hypertensive and what? He has dyslipidemia. So we are back to number 5, which is urgent medical treatment. So the next question is, what other medication will you give these guests in the emergency room? Anyone? Okay. So what we try to do here is, we try to outline the medical treatment you give a patient presenting with acute coronary syndrome. So basically, I want you to think of this mnemonic, MONASH. Patient come with pain, they must be on analgesic, preferably opioid analgesic, so morphine or other opioid. They may need oxygen therapy, especially when their oxygen saturation is low. Nitrates are also important. However, we avoid nitrates, sublingual nitrate or IV in patients with inferior MI because it can tip their BP down and give them hypotension. But generally, it's part of the initial treatment. Antiplatelets are also important, aspirin or clopidogrel. Generally, we give the dual antiplatelets. We start by loading them, then continue with 75 milligram. High-dose statins. We talked about this earlier, the importance of statin when Dr. Fortune was presenting the case. It's not just for lowering the cholesterol. It's also to stabilize that plaque and prevent further rupture. So we give high-dose statin. Then heparin. Heparin is important too to prevent thrombosis from other things, including pulmonary embolism and venous thrombosis, because the condition is actually prothrombotic. It can lead to formation of clot elsewhere. So we give heparin or either unfractionated or enoxaparin. That's MONASH. So for these guests, the guests also came with heart failure. So we gave IV furosemide, captopril, then heparin, then we gave high dose rosuvastatin. So as another point for you to remember, we want to avoid nitrates and beta blockers in patients with inferior myocardial infarction because they are prone to low BP and heart blocks. Because they are prone to what? Low BP and what? Heart blocks. So patients with inferior myocardial infarction, we don't want to give your sublingual nitroglycerin or beta blockers like bisoprolol and the likes. Also, patients with cocaine-induced myocardial infarction. For those that take substance, especially cocaine, they can have myocardial infarction, but we avoid beta blockers in them.
The inferior MI is which leads? ST elevation in which leads? 2, 3, and AVF, Abi. So even though we are saying MONASH, for those ones, that N will not be there. Please, let's remember that. And in Abuja or big places, ask about cocaine. If you give beta blocker there, you will never forget it.
So now the last part is still on the number 5. We talked about initial medical treatment and reperfusion when indicated. So you must remember that time is what? Muscle. If you don't reperfuse and open that occlusion, the muscle will die. A blocked artery every minute to second will lead to increased muscle death, heart failure, and possible what? Death. So it's not enough to say I gave morphine and I gave heparin. You must find a way to open the blocked artery. So these are the reperfusion strategies we have. First line is percutaneous coronary intervention. It's simple. Let me just use a layman language. It's not as simple as I said. Let me use a layman thing. It's to go in there, pass a wire through the blockage, then a balloon over it, open up the blockage, then we put a stent to keep it opened. The second line, in case you are somewhere where you don't have access to PCI and stent, or the patient comes early and they cannot get to where they can get PCI on time, you can give thrombolytic therapy. That's Oteplase, Tenetplase. And in some instances, patient may also need what? Bypass surgery. There are certain instances like people that have all the blood vessels blocked, right coronary, left coronary blocked, people with certain types of lesions, people that have other indications for bypass beyond the blockage and the likes. So these are the three strategies we have. So for thrombolytics, the drugs are as listed, the strategies are as listed. So emergent reperfusion is the immediate priority. If you reperfuse the patient on time, you get favorable long-term outcome. So it's very important. It's not enough to just give aspirin and statin. So our aim is to reperfuse someone within 1 hour of arriving at the hospital. However, this is very important. If you are working in my village, and my village is 1 hour away, and the patient presented to you with STEMI, and you know you can do the initial management and get the patient to reach Cardiocare before 2 hours, transfer the patient. If you are also in my village, and my village is still 1 hour, but you know you will not have time, or it will be delayed, you can do initial thrombolytic therapy and transfer the patient afterwards. So when we do that, we call it what? A pharmaco-invasive approach. So you give initial thrombolytic therapy. If you are not going to get the patient to a PCI-enabled facility within 2 hours, then afterward you transfer the patient. Is that clear? Is that clear? So we are saying if you cannot get the patient to get the first line treatment, which is PCI, in 2 hours, give thrombolytics first, then transfer. But if you can get the patient to where they can get the first line treatment, transfer the patient. Is that clear? Is that clear? Thank you. So we've talked about the for patient with non-ST elevation acute coronary syndrome, either end-stage or unstable angina, the Monash, that's the initial medical treatment, is still there. We re-stratify them. We don't give thrombolytics in this patient at all. We don't give thrombolytics. We either do a PCI or we do bypass surgery. But we don't also do reperfusion for everybody. Only those that are high risk. So I will tell you some of the high risk features. So these are some of the high risk features you should note. Patients that come in shock or cardiac arrest, patients with ventricular arrhythmias, especially those that lead to cardiac arrest, patients coming with acute heart failure and they have non-ST elevation acute coronary syndrome, or the chest pain is persistent despite all the medical therapy. So an important point is that after all this, we've gone through the 5 steps. We said the first one is identifying the chest pain. Next is what? ECG. Third one is what? Troponin, the enzymes. Number 4, cardiovascular risk factor. Number 5, immediate treatment and what? Reperfusion. So after doing all this, we must prevent a repeat. Now, I started with atherosclerosis and I said we have a blockage that leads to what? Myocardial infarction. The same thing is going on elsewhere, in the brain, in the leg. So patients with myocardial infarction are prone to what? A repeat one, a repeat acute coronary syndrome. They are also prone to stroke. They are also prone to peripheral artery disease. Beyond the heart failure and cardiac arrest, they are prone to. So you don't want that. So secondary prevention is invaluable. So we start with lipid lowering. All patients must be on high dose statin. Our target is what? Less than 55. But if they have had repeated episodes, they become what? Very high risk. And we say the target for that will be what? Less than 40. So, but they are coming for the first time. Acute coronary syndrome, target is less than 55 milligram per DL. For the sugar, we said the target is less, hemoglobin A1C less than what? 7%. Now, they must be on antiplatelets. On it, compulsory. our chief presented a case yesterday about somebody that went to a pharmacy with dual antiplatelet and he wants to renew his drug, and the pharmacy was like, aspirin and clopidogrel, they are doing the same thing. Remove this one. And the stent he had got blocked, and he presented with what? Another episode, and he died. So it's dual antiplatelet. The two must be on for at least 9 to 12 months. In our facility, we do 9 months. Others do 12 months. You can extend depending on the case. So other things we give are beta blockers, other heart failure medications, especially the EF is low, like ACI-ARB, mineralocorticoid antagonist. Now, there was a question about the role of all other health workers in managing this patient. The physiotherapy was asking the question yesterday, that what is their role? So we have a comprehensive program called cardiac rehabilitation for cardiovascular prevention, especially secondary prevention. And it involves exercise training, nutrition. So the physiotherapy is there, nutritionists are involved, weight management, endocrinologists may also be involved, blood pressure management, lipid management, diabetes management. Smoking cessation is also part of it. Then we have psychosocial management. These illnesses are bad. People have PTSD from just suffering from stroke or acute coronary syndrome. People are trying to adjust. People will need some psychosocial assessment and management. So all these are components of cardiac rehabilitation. You can see it involves a lot of what? Subspecialty. And all this will help the patient and prevent a recurrence of what? Acute coronary syndrome. So don't forget, we talked about the diagnostic framework. We said 5 steps. Who can remember them? 5 steps. Anyone? We started with what? Chest pain, right? Next, we said what? ECG. Next, we said troponins. Next, we said cardiovascular risk factor. And number 5, we said so immediate treatment and reperfusion when indicated. We also said the initial management is what? Monash. Abi? So for pain, we said morphine. Abi? Oxygen when the oxygen is low. N is what? Nitrates.
Nitrates except in where?
Except in what?
Inferior stemi, right?
Except in inferior stemi. Then we said A is what? Antiplatelets. So we talk of aspirin and clopidogrel.
Together, 300.
Together.
And
please.
all of this treatment should be done within 5 minutes of person getting into the facility. Everything, 10 minutes, it should be done. ECG, all of this should have been done.
S is what? High dose statins. H is what? Heparin. So this is initial management. And we said reperfusion is important because time is muscle. Time is muscle. So it's not enough. You must open the blocked artery. Otherwise, the muscle will die. Patient goes into heart failure and possible cardiac arrest. Then we say secondary prevention is as simple as A, B, C, D. I think I've removed that.